Okay, I think we'll get started. We're at 8:31. So for everyone online, we're just going to get started as well now. Start with the land acknowledgement. Ottawa is built on the unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land, as well as all First Nations, Inuit, and Métis people. Today, our talk, the slide is up with the title, so Sexual and Reproductive Health Promotion, an upstream response to sexual violence against children and youth. Our speakers today are, someone's doodling on their screen. Okay, perfect.
Sweet.
Yeah. They're taking notes already, so that's great. So Marita has worked in the emergency department for over a decade. Her work and observations with the sexual assault care program highlighted the significant needs for sexual and reproductive health promotion in the pediatric population, leading to pursuing an independent practice as a sexual health educator. Both bios are actually nice and short, so I'm just reading them. Usually I paraphrase them. Dr. Rochelle Einboden has worked as a pediatric nurse for over 25 years and is currently an associate professor at U Ottawa and nursing research chair at CHEO and the CHEO. Her research uses critical social and feminist approaches to study violence, including sexual violence and child protection. So I think we're up for an interesting talk today. So Marita, over to you.
Thank you so much. It's great to be here to talk about the Advanced Practice Clinical Fellowship that I completed last year with the help of many of you in this room. As you can see, there's also a few other folks on the slide, and we'll introduce Debbie and Bria and Jamie as well a little bit later because they're going to be sharing some of their slides as well. And there we go. I just wanted to return us back to that land acknowledgement that we just did. It's really important to me that when we give land acknowledgements that we connect it to our practice and to the work that we're actually doing. And when we're talking about sexual health, sexual violence, it's deeply connected to structural inequalities, to the use of power and how power works in our communities. And so I just wanted to highlight the national inquiry into the missing and murdered Indigenous women and girls as well. Many of you are familiar, but that was a report that was done between 2015 and 2019. We have 231 calls to justice that came out of that report. And we have not made great progress on actioning those calls. But the one I wanted to highlight is this one around trauma and violence-informed care, really, is what it's about. So understanding our history, our current moment, and the ongoing colonization that's happening in our communities today is a really important part of how we deliver care. And so you'll hear us talk about that throughout the presentation. And then the art is from one of my favorite artists, Emily K. Wagashik, and it's honoring the women who are missing and murdered and the women who are still here. So I wanted to start just with the definition of sexual health. This is from the World Health Organization, and I sort of made a shortened version because it's quite long, but highlighting the fundamental aspect of sexual health to overall health. I think often we think of, it's often very segregated into sort of specific things like STI testing, and then we kind of move on and don't think about it, rather than thinking of sexual health as an integrated part of all overall health, and the impact on public health in our communities. Just because sex is a private thing that we think of as private doesn't mean that it's not impacting our communities in really profound ways. And it also requires a positive approach, and we'll talk more about that in a little bit. And the access to pleasure. Accessing pleasurable and safe sexual experiences that are free of coercion, discrimination, and violence is, I think, something that we don't necessarily talk enough about. And then finally, the ability of men and women to achieve sexual health and well-being depends on several things. Again, there's more things on the list, but the two I'm highlighting are the access to information and the environment that promotes sexual health. I'm curious to hear from those of you that are here, and if anybody online, what do you think is missing in terms of the pediatric sexual health from this definition? It's very clearly talking about men and women, which to me that kind of jumps out as gendered initially. Is there anything else that's missing from this definition?
It doesn't talk for children though.
No. So it doesn't talk about sort of sexual development, supporting children through sexual development, through puberty, through the lifespan. And I think that's a pretty important piece that we miss. So for the project, my initial question really that came out of my work as a sexual assault nurse examiner was, how can we do better? Because I found that not only did really 100% of the patients and families that came to see us had a lot of education and information needs, but a lot of times we weren't necessarily able to fill those needs as providers because we didn't have what we needed ourselves. And so I started off just by looking at the literature to see, what are best practices, what kind of guidelines are available, what are other people doing, what are other people talking about. And I really found that although there are different literature that talk about what best practices might be, there aren't like a sort of consistent set of guidelines or, for example, the RNAO has lots of different best practices for adolescent health information delivery and nothing for sexual health. I also wanted to understand who we have at CHEO. So we have some people in this room today that are doing this work, are subject matter experts, and you'll hear from some of them. But I found in my clinical work, a lot of times we don't know who those people are or where to send folks. And then increasing that access to the information that we do have, making sure people know who to refer where and that kind of thing. And then thinking about the community. So it's really important to me to think about getting input from parents and youth. And so we'll talk about that and thinking about other community agencies that can support us with this work. It's important to situate ourselves in the context of sexual violence. So most of you know it's extremely prevalent, particularly among children. So up to just under 10% is sort of the official Statistics Canada number where people experience sexual abuse before age 15. Ages 12 to 24 is also the highest rate of things like intimate partner violence, sexual assault, sex trafficking. And so this really is a problem with our population. And sex education is a really effective upstream approach. That's really clear in the literature. I'm not going to go too far into sort of that argument today because it's just very clear that it works. The impact of sexual violence on mental health is one thing I wanted to also highlight. We see a lot of patients in Emerge with mental health, and a lot of them have sexual assault and trafficking and other childhood sexual abuse, things like that, in their history. And in my experience, we have services for acute sexual assault, but when it comes to supporting people with a history who need counseling that are not in the acute phase, even when they're in the acute phase, sometimes we struggle too, but getting access to counseling and therapy, particularly if they don't have access to insurance, is really, really, really difficult. So a couple things just to highlight: psychogenic seizures. A presentation of psychogenic seizures indicates that individual has about a 3 times odds of having a history of child sexual abuse. So if we're not thinking about what could be the underlying issue that's causing this mental health presentation, we're treating symptoms and we're not treating the underlying cause. There's also an association with borderline personality disorder, and I can tell you, those of us who work with trafficked youth, a huge percentage of those youth that we work with have diagnosis of borderline personality disorder, bipolar disorder, psychosis, and really serious mental health issues. And again, not always treating them for the underlying reasons. Lots more: depression, self-esteem. Certainly eating disorders also has a really high correlation with sexual abuse. I also wanted to just put this out there because I think this is important. The hypersexualization that can come, not necessarily, but can come from child sexual abuse and sexual assault, we often can read that through a lens of stigma, through a lens of, oh, this person's engaging in really harmful sexual activity, or, we can think of all kinds of slurs that go around in society about young people that engage in a lot of sexual activity. And we know that this is something that can be associated with sexual abuse. And again, perpetrators also typically have about a 30% rate of child sexual abuse versus that 10%. So when we think about prevention, we think about education, we're not just thinking about preventing people from getting assaulted, which is a lot of times where the focus is. The focus is on preventing women and girls from being assaulted, rather than thinking about what are the overall societal conversations we need to have in education for boys and men who are more likely to be the ones assaulting, although it does happen between from all genders. So if sex education is an effective approach, why don't we do it well? A couple examples just from the literature. This was from a US study, but they found that the average time of sexuality talk for adolescent health visits was about 36 seconds, which doesn't seem very effective to me. And nurses are also not prepared, not trained. Nursing and medical school does not provide a lot of sexual health content. And this one, I think, is Rochelle. So I'm going to bring Rochelle up to give us a little bit of the why.
Thanks, Marita. When Marita and I were having kind of conversations trying to unpack what's going on here, because it seems quite simple, right? Sexual health is part of a holistic approach to our health, but we sort of don't talk about it. So there's a lot of ideas in society that produce this not talking about it. So there's structures around not talking about sexuality with children, not thinking of children as sexual beings. And when we withhold that education, we produce their vulnerability. Instead of thinking of children as vulnerable generally and should be protected from ideas of sex, we're actually producing vulnerability by not talking about sex. There's little animations here. Let me just open those. So there's this sort of idea that children will be corrupted or their innocence will be disrupted if we were to talk about sex with them. And so there's these ideas that it's dangerous, right? So, and definitely that it's not something that clinicians would lead. Of course, we need to be respectful of parents, and there's a lot of pushback in society about talking to children about sex. So when we have barriers to knowledge like this for children, we need to then think about, well, how does that work? How does that refusing to talk about sex education and talk about sexuality with children, how does it operate in society? And from, this work, but also for other research studies that I have been working on actually recently and previously, what really comes up is the operations of ignorance around sexuality for children means that they can't disclose sexual violence. So if you use, for example, and this came up in another study we're currently doing, if you use language like food for genitalia, all of a sudden, when a child discloses sexual assault, they're talking about, and this was a quote from one of my other studies, someone touched my taco. That doesn't mean anything, right? So what it does is the ignorance that we enforce on children prevents them from disclosing sexual assault. So that's an operation that we need to be thinking of. And these ideologies of innocence justifies our paternalisms toward children and the kind of like drip feeding whatever information we think they should have in our society. So not only we keep children in the dark, when Marita and I were talking about this again, we were like, we're keeping clinicians in the dark, which is really kind of conceptually interesting. Because generally clinicians are pretty confident about being experts in things and pretty confident about, well, this is what we need, so we're going to do it. But in this case, we don't. So how is it that we have actually removed that expertise from clinicians as well? Well, it's not prioritized in curriculum across disciplines. That's one way. And instead, we have these ideas, what I would call from other research to ideological figurations, that they focus us as clinicians on forensic and medical practices of visualizing violence on children's bodies, instead of offering a practical approach to disrupting sexual violence through sexual and reproductive health promotion in the first instance. And how that works is it preserves sexual violence in our society. So the idea is that children are vulnerable rather than vulnerabilized by ignorance. And the idea is that perpetrators are monstrous orient us to retributive justice as a mechanism to deal with sexual violence, when in fact that's always too late. And tends to be not very well. We know that our court systems don't do well on that. So when children have experienced sexual violence, it's rarely seen on their bodies. And in fact, because of that, it works paradoxically in terms of legal retribution. So there is no retribution. So essentially, there's no way to address sexual violence in our society with a forensic and medical approach, unless it's really extreme. So the extremes, it works well, but it's actually turning clinicians' gaze away from most of the sexual assault that happens. And also we have this, the idea of the monstrous perpetrator supports the retributive justice approach, but it also takes it out of where sexual violence usually occurs, which is often with people close to the child. So they're not strangers. And it's not the stranger danger ideology, and it's not this monstrous person. It's actually somebody who's often in caregiving relationships with them as well. So I'll just read this quote. I don't know if you've had a chance to read it, but despite the highest prevalence of child neglect and abuse is related to neglect, emotional abuse, or the harms of intimate partner violence, the monstrous perpetrator supports a focus on visible and abject horrors of physical and sexual abuse, detracting from the social conditions that contribute to, and I would say produce, children's vulnerability. And one of those social conditions is what we're talking about today, is that ignorance of sexuality and healthy sexuality. And that's how it operates.
Thank you so much, Rochelle. So how that ignorance works and what it looks like happens at a couple different levels. And so I found this just sort of infographic helpful. And these three, the little picture came from one particular article, but these three themes came up all over the literature, where we have these personal knowledge gaps, unconscious bias, communication issues. Those are some things that came up a lot. But then we also, at the organizational level, again, we have that lack of education, lack of training, specific training to, for example, navigate a disclosure of childhood sexual abuse or something like that. And then the limitations that we have in trauma and violence informed approaches. At the structural level, this one's, it feels a lot bigger, because these are issues that none of us can tackle on our own. But there are things that we need to be aware of and conscious of that are happening and that are operationalizing some of the things that Rochelle was talking about. I don't think I have to go into detail about economic constraints. I think most of us are pretty familiar. But specifically when it comes to this work, I can tell you that a lot of the work that's done at CHEO for sexual and reproductive health promotion, from folks that are here, from Debbie's going to talk to us about the work that Adolescent Health does, and Seb is also here from the Gender Clinic, and I know that both of them have done a lot of work in this kind of education, and that often happens off the side of our desks, and it's not happening as part of our paid role. So there's some really specific examples of how that ignorance is produced. I also just wanted to highlight this quote. We're going to come back to this one. This is another example of ignorance that is produced in medical education. We have a lot of textbooks from different points in history where the anatomy of the clitoris is just absent. It's not there at all. And we'll come back to that in a minute. This is just another way of looking at those structural pieces. So Galtung is a peace researcher from a couple decades ago. He built the Institute of Peace Research in, I believe it was Sweden, Norway, one of the two. And he conceptualizes these sort of three domains, the cultural, structural, and behavioral, as all sort of working together and informing each other. So you have culture where, for example, rape culture, where sexual assault is trivialized, boys will be boys, locker room talk, that sort of thing. And that culture is working when laws and policy are being developed, for example, whether it's for response to sexual abuse, whether it's how we deliver sex ed. We have another example of that culture informing policy right now with the discourse around trans youth and their rights and whether they should have access to healthcare or not. And then that directly informs legislation and policy. And both of those things make that direct violence that happens towards children, it makes it invisible, it makes it impossible to address, and it actually makes it normalizes it. So going back to the idea that power is a really important piece of this, the people with the least amount of power are going to be the most affected. It's a pretty straightforward math. There's a couple of things that came up in the literature sort of over and over as gaps. So child sexual development, we kind of touched on that already. It just is missing from medical nursing education, from research. And that obviously impacts how we address sexuality with all children, as Rochelle was talking about. But folks with disabilities are significantly left out. And we're going to hear from Priya a little bit about what neurodevelopmental health is doing. 2S LGBTQIA+ specifically, a lot of times, for example, trans kids don't see themselves in sex education, and so they're not getting the information they need. Healthcare isn't always accessible. Research isn't always there. Research is often focused, even you'll hear in this presentation, a lot of the research is sort of male, female kind of thing. And then, of course, we talked about Indigenous people and the disproportionate rates of sexual violence. The needs and experiences of male youth was interesting to me because we don't necessarily think of male youth as a group that is necessarily marginalized. But when it comes to sexual health education and research, they actually do get left out. So a lot of the research looks at sexual health in young women. And that, I think, has to do more with how we conceptualize who has access to agency and who should be controlled. And we'll talk about that in a minute. But male youth often aren't offered sexual health education and information at their visits. So, for example, one of the studies cited here noted that young teenage girls who were being offered healthcare were 3 times more likely to have a conversation about condoms than the males, which seems a bit odd to me. And then these are just some kind of comments that talk about the ways that sexual and reproductive health inequities are understood as that broad interrelated social determinants of health. Again, it's integrated into the broader aspects of health in a way that is not often talked about. So what does good sex ed look like? What does good sexual health promotion look like? We're going to go through these 4 pieces in a little bit more detail. So we need to start early. For a lot of us, we kind of think of our own sexual health education. Maybe some of us had the talk, but starting sex ed in adolescence or at puberty is not enough. As Rochelle mentioned, like understanding names for anatomy, understanding safe and unsafe touch, consent, all these things need to start really, really early. Understanding and supporting gender, as we talked about sexual development throughout childhood, those are all things that health providers have an important role in. Gender and power is another really important one when we think about preventing sexual violence. Those sort of behaviors that can get normalized in childhood that really end up developing into unhealthy dynamics between the genders. Being able to recognize and support people experiencing sexual violence is something that, again, we've talked about here as something that we don't always do well. Again, the interconnectedness of mental health and sexual health. And then information and counseling for young people with health diagnoses. So this was interesting to me because it wasn't something that I have experience with, but folks with oncology diagnoses, people who are taking medications that can impact their fertility, it isn't necessarily straightforward or easy to think about talking to a 10-year-old or a 12-year-old or an 8-year-old about their future fertility. But kids go through some really big stuff with their health that is going to impact their future. And if we're not honest with them, again, withholding that information because we want to protect them, is not actually protecting them at all. Another thing that was really interesting in the research was the conversations about pleasure. So again, in that definition we talked about at the beginning, we don't have sex for reproduction all the time, right? We have sex for reproduction some of the time. But when we talk about sex education, that's often how we talk about it. And so if we talk only about the negative aspects of sex, so how not to get an STI, how not to get assaulted, how not to get pregnant, we're really presenting sex as something that is dangerous, that is scary, that is potentially really uncomfortable. And that makes it really hard for people to recognize what a healthy, positive, enjoyable sexual encounter might look like. And so there's some really great research coming out of specifically, there's an organization called the Pleasure Project, which is incorporates researchers from all over the world that is looking at how to incorporate pleasure into sexual health education and health promotion in a way that can be more holistic and more positive about our approach. So some of the benefits that they're finding is that people actually will use health services more if there is that positive approach. People will use condoms more, have less risk-taking. It also really helps with that shame and guilt messaging. I was talking to someone recently that was asking, I've heard that young people are having less sex. Is that true? Is it not true? It is true. Young people now have less sex than previous generations. And they were saying, that doesn't really make sense to me because we're really permissive about sex. And it's true that we have more permissiveness now perhaps than we did decades ago, but we also have a culture of over-sexualizing children, and particularly young girls. We commodify and we market their sexuality, but we don't give them access to it themselves. We don't give people ownership over their sexuality. And so telling people an honest, holistic approach to sexuality, including pleasure, can help to combat some of that shame and guilt and some of those negative aspects that young people are exposed to. Helps them identify unhealthy messaging, again, empowerment, healthy relationship development, and inclusion of sexual diversity. So if we're just talking about sex as reproduction, we're talking about penis and vagina sex. And that is not representative of all of the different ways that humans engage in sexual activity and all of the reasons that they engage in sexual activity. So talking about pleasure allows us to have a better conversation with all genders, with all kinds of people with different sexual orientations and how they engage in their sexual life. I just wanted to point this out. I thought it was interesting. The Canadian Pediatric Society has a comprehensive sexual health assessment guide for adolescents, and they chose peace, and they chose 7 Ps, and they did not include pleasure. So trauma and violence-informed care, we've talked about this a little bit, so I just wanted to highlight the 4 principles just to sort of review. I'm sure you're all familiar. Public Health has these on their website. This particular one is from a book by some researchers from Ontario who really look at they really highlight the structural piece. So they've added the structural violence, the prevalence of sexual violence here, and they include the importance of cultural safety when we're talking about those emotionally and physically safe environments for people, and to really celebrate those opportunities for choice, collaboration, and connection, and a strengths-based and capacity-building approach to support access to service. And we'll talk about some of the examples of what that's going to look like in practice. So this is that same infographic. So rather than looking at the barriers, this one just looks at some of the potential solutions and to look at those different sites where the barriers live as a place where we can get some change. So on a personal level, for example, myself, when I recognized, wow, I'm delivering this care, I have all these questions from parents that I don't know how to answer, I had to go and do my own education to fill in my own knowledge gaps, and I had to really sort of work to build a team, to build a community of people within CHEO and within the community to help me answer those questions that I didn't know how to answer. The reflection on personal bias is really important when we're talking to young people or anybody about their sexual health, because if we have that personal bias, it's going to come up and it's going to show. The literature and the conversations about communication was really interesting, because it was really clear that when young people were sort of part of the research, they would say very clearly, the biggest barrier to me talking about my sexual health is that the person is judgmental, they're not open, they don't want to talk about it, they're uncomfortable. And so being able to show up with non-judgment, with a comfort level in the topic, is the difference between somebody actually being able to access service and not. And then again, the need for education, training, funding, and these are not things that any of us can do on our own. These are things that we have to collaborate. And I just thought this quote was interesting. The sort of focus on partnerships that prescribe interventions. So the focus on, again, like Rochelle was saying, like we do a medical exam, we do a forensic exam, we send somebody for therapy, but we're not looking at what is needed in the community to identify what is actually happening. We have a trauma program here that has done a huge amount of education and sort of initiatives around helmet wearing and making sure people have car seats and thinking about how we can prevent some of these, prevent the traumas so that we don't have to take care of them and so that the families don't have to experience them. We're not doing the same thing with sexual violence. But we are doing some things. So at CHEO, we have, I mentioned the Adolescent Health Clinic and the Gender Clinic. We have Debbie here. She's going to speak to some of the things that they're doing. We have the Gynecology Clinic, and we have Jamie online. That she's going to present some slides as well. Hopefully the online, it will all work. We have Bria from Neurodevelopmental Health, and she's going to share a little bit about what they do. And then there's also, of course, infectious disease, who provides things like STI testing, vaccination, HIV, PEP, and PrEP. Unfortunately, they aren't here to talk with us, but they did a lot with the project as well. And then, of course, sexual assault care. They're a really important part of education and awareness at CHEO. And also, I didn't have it on the slide, but the Child and Youth Protection Team also works closely with the sexual assault care team to provide that as well. And then in the community, most of you know, but we do have the Sexual Health Clinic with Ottawa Public Health. They do see young people, so that is a place that we can refer. And then there's some Indigenous specific services. Minwashen has some anti-trafficking programs, which are really great. Wabano has clinic services. So just to know that when we have Indigenous clients, they may not be comfortable talking about their needs or getting their needs met at CHEO, but to know where we can send these folks if we need to. Aunties on the Road is a full spectrum doula service, but they also offer a lot of sexual health education that's really great. Just wanted to highlight Planned Parenthood. They're another example of a community organization that currently has lost funding through the wage cuts. So all of the services that they offered, like pregnancy counseling, STIs, treatment, safer sex supplies, those resources are now no longer available in the community. Hopefully they will get funding again, but that's where we're at right now. So Debbie's going to come and share.
Thanks, Marita. I'm Debbie Turner. I'm the nurse case manager in the Adolescent Health Clinic. And I just wanted to share a little bit about what our clinic does and sort of how we operate. I'm just going to put my glasses on here. So the biggest thing I can say that we like to focus on in our clinic is that word that you keep hearing is empowerment. I think the youth at CHEO need their voices heard, and that's the one big thing that we work on in our clinic. Is empowering them. And that can be done in simple ways. We highlight the need for privacy and respect regarding their health information and their ages. So making sure that we're speaking to them when we call the home or calling for results. It's allowing them to take control over who gets their information and what information they get. A few of the things we do, you can see here in our list what we do in the clinic. Teen pregnancy, so we do options counseling, education, care planning, and support. Often the referrals surprisingly come from Emerge, where it's a surprise announcement that someone finds out they're pregnant. So we see them quite quickly and help to empower them to make the right choices for their needs. We do a large amount of contraception and menstrual suppression consultations. So that includes education to help them make informed choices and options, which, non-surprisingly, they often don't know a lot about their choices. When we talk about LARC, so long-acting contraceptions, IUDs, implants, they often kind of have heard about it. Maybe that's on TikTok or, through a friend. And so we do a lot of mudding through the weeds to try to give them the right information to make good choices. Again, we talk about the male, female. So in our clinic, we see a lot of gender diverse youth. And so how we speak to them about menstrual suppression sometimes is a little bit different. And the choices they make can be different. So we have a little bit of expertise along that line, actually a lot of expertise in that line, on how to manage these youth and help them make the best choices for them. Sexual assault, we do the follow-ups from the Emerge, and Marita talked about historical assault, so there often aren't services for them. We do see them in our clinic and try to connect them as best we can with services, and sometimes it's as simple as them needing discussions around contraception and just support navigating maybe therapy that they're having within the community. We do a lot of STI education, screening and treatment, of course, exploring sexuality and sexual health. It is not surprising when they come to our clinic, even at 16 and 17, that they're very limited amount of education that they've received on those topics. And they'll come maybe for a sexual assault follow-up and then stay coming to our clinic for a long period of time because they feel it's a safe and welcoming place to talk about those type of things. We work on teen relationships, social issues, a lot of high-risk teen behaviors. Whatever their needs are, we try to manage them within our program. We do community-based programs on the outreach where we go out into the communities. So often as Dr. Harrison and myself, we have a clinic that we run every couple of weeks at the Uville Center. So these are young women who have had babies or having babies, where we give them support. And we do a lot of work on sexual education at that center, believe it or not. These are young women who have had babies who really have very limited education when it comes to their sexuality. And we also do an outreach clinic at the Young Women's Shelter, and Seb joins us there too for some social work support. So these are young women living on their own, often at 15, 16, seeking some help. And so we do a lot of work connecting them with people. So just always to know that we accept referrals from anywhere, pretty much from anybody. And if you're not sure if we can help, we probably can in some way. So don't be shy to send us a referral. And the biggest thing I want to talk about too is the ability to speak to the youth. And it doesn't always happen on the first visit. It happens sometimes after the third or fourth one. So we do a lot of work in being patient, allowing them missed appointments, we rebook them, we call them, and then until they feel comfortable, and then they want to share. So that's a big part of what we do is making it comfortable for them to speak with us. And I know sometimes in a clinical setting, whether it's an Emerge or an inpatient consult, you don't have time, like this 36 seconds sticks in my head, because that is probably a big reality. So you're not going to get much in 36 seconds. Our appointments often for a new patient are an hour and a half, and it's probably in the last 15 minutes where they start to open up and give us a lot of information. So if you don't have the time and you see there's some interest, definitely send them our way, and we're happy to see them. So one more. Okay, here's a couple practical tips. Marita put put these together for us. And these are things that we do within our clinic, but you can do this anywhere. So create an environment that welcomes the conversations. If you're seeing someone, an inpatient, and there's a patient in the bed next to them with the curtain drawn, you're not going to get a whole lot of information. So be mindful of privacy and confidentiality. A big thing too is normalizing the routine nature of the conversation, so allowing them to speak in the language that they use. Sometimes it can be colorful, but if that's what makes them comfortable, then you have to make that acceptable. A positive client-centered approach is going to give you that client trust, which often again takes time. A big one is open-ended questions, allowing them to share what they want to share. Giving some leading so that they can kind of feel that, oh yeah, I could probably talk about that, because sometimes they'll say this feels really awkward, and usually when they're saying that it's because it is, and especially for them. And so you also, in the last comment here, self-reflection to address your personal attitudes. So we have to be really open and be mindful of our judgment and our own attitudes. So it is, like it says here, the key hindrance to the adolescent use of services is not feeling overly comfortable with maybe someone judging them. So we do hear that a lot, that, well, I couldn't talk about it because, or my family doctor, I can't go to them because they don't like to talk about sex. So it is a common comment that we hear. And so we're hoping with all these projects and this work to change some of that. And I think for pediatricians and pediatric providers in the community, it's really important that this become a part of their work. So thanks, everybody.
So we'll try to speed up a little because we are getting close to time to make sure we have conversation. Jamie, I don't know if you're able to unmute and jump in here.
I think, can you hear me?
Yeah, we can hear you. Can you guys hear?
Perfect. Okay. Perfect. Thank you so much for having me. This is a great presentation. So yes, I am one of the main gynecology nurses in the C9 clinic for the gynecology. And we do a lot of sexual health in our clinic, as well as a very broad gynecology related services. So sexual health is not our main focus, but it is still a big part of our clinic as well. And like, sexual health is a part of everyday life, and children and young are vulnerable position every day, especially these days with AI and the very easy access to social media, TikTok, Facebook, Instagram. There is such a large volume of information that is unfortunately often incorrect or very prejudiced in one direction. And so kids have a hard time filtering through that information and knowing what is real, what is false, in what they should trust with this information. And so when they come, sometimes they have obscure questions that they will come. And so, like Debbie said, the practical tips are super helpful because it is really important to be very open to any and all of their questions without judgment. And like, sometimes they come up with very weird questions, and you're just like, where did this even come from? It's important to just digest the question and just be open. And it's okay if you don't know the answer. You say, you know what, I'm not quite sure what the answer should be. Let me ask a colleague. Let me reach out to someone who has more information, and let me get back to you. Most patients will respond well to it. And you also see sometimes the lack of education is coming from the parents. Sometimes when I'm doing education with mom and daughter or patient, you'll see that the parents is also asking question, and you see the lack of knowledge coming from them as well. So if they are lacking the knowledge, they're not able to appropriately speak to their children about these things because they're also lacking the knowledge. So accepting also the parents' question is also super important as well. And we also accept referrals from everyone. We're happy to see any patients for any questions, whether sexual health related or just gynecology related issues. Maritha, can you switch to the other side? We also do in our clinic, we do a heads assessment for all of our patients. And this is done dependent on age. So sometimes it will be depending on like if it's a very young child and they're not able to fully answer questions, or if they have learning disabilities or mental health issues or mental disabilities, they will sometimes have a parent present, or even a teenager. Sometimes they're not comfortable to have private time with a doctor, which is completely acceptable. We do try to do social histories with an age appropriate, and if they have the ability to do it by themselves, to give them confidence and get them used to being able to have the ability to ask questions. Because oftentimes you'll see kids with the parents, and the kids always defer to the parents to answer any and all questions, regardless of the question. So it gives them the ability to be able to practice these skills, to be able to advocate for themselves. And like we often forget that these kids are going to be adults soon. And so they're going to have to do this by themselves at some point. So giving them that ability is super important. And so some of these are sample questions that we'll ask and go through. This is not, we also go through like safety at home and eating habits and other things, but these are a lot of the questions that we'll go through and answer if it needs to be answered. Yeah. Thank you.
Thanks so much, Jamie. So, and then Bria's going to come up, and I'm sorry, we're running.
Good morning, everyone. My name is Bria Martin, and I'm a child and youth counselor in the neurodevelopmental health department. I want to say that sexual and reproductive health really develops a youth's ability to self-advocate and their sense of autonomy. So I'm very grateful today to be surrounded by a community of people who really value that. Neurodevelopmental health is an outpatient department, meaning that we can provide services in any of our centers, which include Cornwall, Renfrew, Canada, and 2 Ottawa sites. But we also provide some virtual and in-home services to really make this accessible for our youth. 3 of the programs I'm going to talk about today are Foundational Family Services, Urgent Response Services, and Extensive Needs Services. I want to highlight that these programs focus on a lot of behavioral and mental health needs, but today I'm just going to talk about how we support youth at risk of exploitation and youth engaging in unsafe sexual behaviors. Our Foundational Family Services is funded by the OAP, Ontario Autism Program, so it's intended entirely for youth with autism, and it supports youth up to the age of 18. Foundational Family Services has 2 workshops, one that teaches youth about puberty, which is very essential because oftentimes our youth feel like they're the only person in the world with a disability. It's really lovely for them to learn alongside other people with disabilities because they feel more comfortable and they get to learn with other people who have the same barriers as them. They also have a sexuality workshop where they talk to caregivers who have youth over the age of 13, and they really teach parents how can you talk to your youth about sexuality so that they can build that confidence in that relationship. They also provide some one-to-one consultations. Our URS program is also funded by the OAP and is also up for youth up to the age of 18. We do a lot of one-to-one coaching, which I'll talk about in the next slide, but it's all about developing the youth's sense of autonomy, teaching them appropriate ways to engage in sexuality, and also teach the parents how to respond to different behaviors. Our extensive needs services is available for youth who have multiple medical, neurodevelopmental, and mental health needs. So different to FOFA and URS, we accept youth who have more than just autism and different needs. What does one-to-one coaching look like? So for URS and ENS, it is really based on one-to-one coaching. We have behavior analysis and behavior therapists who coach the parents on how to respond to various behaviors. We have social workers who can provide education and mental health to caregivers. And then I'm a child and youth counselor. I work directly with the youth to help develop their skill set of healthy sexuality. So while I talk, you can see on the right a lot of the common topics that I like to focus on with youth. Our goals are really to empower the youth to advocate for their needs, and as we talked about earlier in the presentation, develop their vocabulary so that they can communicate what's going wrong in their life and what they need support with. We want to provide developmentally appropriate education because that's something a lot of clinicians struggle with is how do I adapt this information so that we can prioritize what's most important to a youth that might take a longer period of time to learn certain skill sets. We want to really develop the dialogue between caregivers and clients because we're not going to be there forever. Their parents are going to be there to support them way more long-term than we are. So if we can develop that relationship, that's essential. And we really want to encourage safe practices. If not safe, we want to focus on harm reduction. Why it matters. We have so many caregivers that feel unequipped to deliver sexual reproductive health information. I have caregivers who say, I really value this information, but I was hoping you can teach it because I'm so worried that I'll get it wrong. I just haven't ever had any talks with the youth. Youth with disabilities often lack peer support to learn socially, resulting in youth searching for information online. I have a youth that she doesn't have the same type of friendships that neurotypical youth often have, so she's making friends online, and she was engaging in solo sex, or masturbation as we call it, with sharp household items. So we focused on how can you reach pleasure, again, because we're really supporting pleasure and having non-judgment, but not using unsafe household items. A lot of youth who attend specialized programs are attending half days, so they're not prioritizing health. They're mostly focusing on things like math and English. So we have so many youth that don't receive this information because it's not a priority. And then again, we teach our youth how to advocate for themselves and respect the boundaries of others so that we're preventing not just people becoming victims of sexual assault, but also people being perpetrators of sexual assault.
Thank you so much, Priya. That service was something I didn't know a lot about when I started, so it was really interesting through this project to see how much they're doing in this area. I know we're at time. We got to do questions. I just really quickly want to tell you one of the things that we're working on still through comms is getting some more resources available on the CHEO website. So you'll see communication once that's live. I do have a resource list that's going to be on SharePoint. So we'll make sure that link is available. In terms of the recommendations from the project, I won't go into detail, but I did want to just let you know we are working on a community of practice to bring together, starting with subject matter experts. So if you're in the audience and this is your subject matter expertise, we want to hear from you. To sort of start talking about clinical challenges and how we can build our capacity, and then eventually providing some education. And so obviously the training and investment in the research is a really important part of that. You'll see the QR code there. That's the final report from the project if you're interested in learning more. And please do feel free to send me an email if you have more questions.
So thanks. Rachel, if you can just take the slides down maybe, and then why don't we start with questions in the room? And then we'll, sorry? Oh, the chat is now up there. Excellent. I thought I said something funny. So yeah, thank you again. Any questions from the room to maybe even kick off discussion? And remember, we just have to repeat the question for the online audience.
Yeah. Thank you. Huge void in what we do, clearly. Family physicians see the vast majority of children and youth in our community. Are you guys doing any work with that group of providers to sort of help normalize some of these conversations?
Yeah, so that's very much part of that community of practice plan. So initially, I would love to connect with other subject matter experts and sort of start to build that. I spoke with some of the folks from Project ECHO, because if you're not familiar with that model, they do community of practice, but they also deliver education. So they have subject matter experts that will create like a 20-minute didactic, and then clinicians can come with a clinical problem, for example, a clinical case that they found difficult. They'll talk about it, they'll do the education, and then all the clinicians in the room can provide input and feedback. So I think that's a really great model. I would love to get Project Echo funding, but that seems like a big undertaking. But yes, that's really the idea of starting with who we have as experts and then extending that out to offering education and offering a space where people can come and have those conversations. Because yeah, I agree, family physicians are, and they want it, they need it. Yeah.
More questions from the room or online, and if you have a question online, you can put your hand up and ask your question live, or just put it in the chat. Megan.
Hi, everyone. Good morning. Thank you for this great presentation. My question is, in terms of the self-reflection, like what are some practical steps for people to do that?
It's a really great question, and it's a big question because there's a lot of different aspects to think about when we think about self-reflection. So positionality, I think, is where I would start. So for myself, I obviously am presenting as a white person. I have immigrant family that came from European countries. And so that situates me in our settler colonial reality as someone who has had to do my own reflection about what that means and how I show up in the world and how that affects the patients that are coming to see me, right? So how patients feel when they have conversations with me. Other reflections that we need to do are reflections around how we view sexuality, how we view people who have a sexuality that's different than ours, a sexual orientation or a gender orientation that's different. What comes up in my body when people ask particular questions? Potentially history of sexual abuse. If I have my own history of trauma, how does that impact how I show up? So it's a really big question. Things that have helped me are reading work by, for example, Black feminists. People like Audre Lorde have been really helpful to me. Tarana Burke, who is sort of the instigator of the Me Too movement from far before we had the hashtags. People like that are people that I look to understand experiences that are different from mine to help me show up in ways that are what the people coming to me need. Yeah, thank you for that question.
Maybe I'll follow up from that question. The adapted figure you had with the three circles, I quickly looked up the paper and I was curious because I was wondering how they were incorporating temporal change. So as you said, youth these days are having less sex, things change over time, but also cultural difference, especially globally, as well as in a multicultural society. And my question is almost more for Rochelle, I think, is how do you incorporate some of these things into a research framework? So, in looking at the limitations of their studies, they were all UK studies that they used in their systematic review. And then they said, however, issues such as sexuality are temporally and culturally determined, and widening the inclusion criteria would have made it difficult to meaningfully synthesize information. I totally get their point, but I didn't have an obvious, then how do you do it, right? Given that it's such a gendered, cultural, and temporal, like these are all really big dimensions. So it's a question of how would you research that? How would you incorporate that into your research? So Rochelle, if you just, because the microphone's only up here. Yeah.
Okay, thank you. I guess it depends on what aspects you're most interested in studying. I think there's some significant similarities, let's say, between kind of Western colonial thoughts that is sort of pervasive, and that's what I would say in terms of the ideology of vulnerability of children and ideologies of perpetrators of sexual assault as monsters. So these are sort of threads, and I would say that those things would be kind of consistent. So there's some cultural aspects that are consistent and dominant. So those kind of ideas are consistent and dominant in white settler society. And so I guess it depends on kind of what questions you'd be asking, how you'd be asking them. Like, are you looking at questions around how to disrupt this, for example? Like that's my kind of primary interest. And I think some of that is just asking the questions. So working on that. And yeah, I think that, that study was limited to the UK, but again, they're sort of a dominant ideological force internationally. And we can see that through the use of English language internationally, right? So that would be, but starting local. So it depends on what you want to do. So I think, for us here as care providers, bringing up the understanding that this is a gap is sort of our first step, and then thinking about what do we think would be meaningful approaches here now. And I think from an organizational perspective, one of the initiatives is to look at how we're incorporating trauma and violence informed aspects of like thinking through trauma and violence in terms of our care. And so as we have those conversations, we do the things that Marita was talking about in terms of understanding our own positionality and understanding our kind of reflections. So a lot of the work is nuanced, is what I would say. You're not going to have, a lot of work that is definitive. But what you can have is work that gets you to think differently, asks you to ask different questions, gets you to understand kind of where we're at now. And that's sort of that first step in implementing trauma and violence informed care, is to take stock of where we're at as care providers. And there's ways to do that in terms of a dialogue and capturing those themes. And so my PhD work looked at the discourses around child protection, and I found that they were figures. And so two of the figures were the vulnerable child and the monstrous perpetrator. And the third figure was around the responsibilization of parents for everything. And so the responsible parent and family was another figure. And these sort of figures work together in particular ways. So it's a different way of thinking about research, and it's a different way of thinking about what kind of knowledge we need in order to create social change, which is what we want to do in this space. Does that answer your question?
To think about it. What I was thinking is, what would I say to close off the session is, it's a very important, complicated topic that needs simplification. Right, both in terms of how do we provide care to this population, which is every child and youth, including child and youth with neurodiversity, or I'm thinking back to Duchenne muscular dystrophy in boys who are really losing their motor function during adolescence, when they're starting to express their sexual being. And losing access to any sexual expression, even from a solo sex point of view, as you were saying. So, it touches on every aspect of the care we provide throughout the institution, not just in the vulnerable population framework, right? So anyway, I'll just say that I'll have to reflect on your answer before I can really understand it. So thank you for introducing, or both introducing for many and also moving forward the conversation and understanding for all. So thanks again.
Thanks.